that, I'm going to announce the winner of the last quiz, Dr. Tapan. Dr. Jaisal will just inform Dr. Tapan. He is the winner of the last quiz. I think the time is over now for the quiz to be displayed. Okay. So now we move on to the next speaker. Like, we are going from the neural circuit towards the spinal stress. So whenever we have a patient who's coming with the low back pain, we have so many things going in our mind. It could be B12 deficiency, D3 deficiency. It could be some weightlifting kind of thing. And so how do we start approaching this patient with the low back pain is a question going through us. And to highlight on these kind of issues, we have with us Dr. Gaurav Ranglani. I welcome you, sir, here. So he's going to talk on the topic back pain and obesity, myths debunked, weight debunked. He's the founder and the director of Alpha Ortho Clinics, Kandivali West. He focuses on simplifying the orthopedic and spine health for the common people, offering advanced, minimal, invasive, and endoscopic spine surgeries. So let's welcome with a big round of applause. Thank you. Over to Dr. Gaurav.
So really thank you for such an overwhelming description. So I'm Dr. Gaurav Ranglani. We are a group of 7 surgeons, and we have chain of clinics across Mumbai called Alpha Ortho. Our concept is basically to treat all the orthopedic conditions directly by specialist orthopedic surgeons. Just allow me a few minutes so that I can make this presentation more interesting. दिखा दो तुम तो। Okay. Start the presentation. Yeah. Rohit. So before I start my presentation, since all of you are sitting right now, I want you to do one little exercise with me. Just try to straighten your left leg like this. Now the other one. Yeah. Since all of you are able to do this, then I can surely say that you don't have an acute slip disc at present. If any one of you has, then please meet me after the session. So I'm going to cover all the themes of today's topic, such as obesity, preventive, and newer advances such as this. So I welcome you all and thank you for this opportunity to present here in front of you. So what every doctor should know is that rising obesity prevalence is there, and because of which back pain is a very common complaint in our OPD. It worsens the spine surgery outcomes, and it is very important to have an early GP intervention in these patients. So how obesity affects spine? It increases the axial load of to the spine, which is very obvious because of the weight. Then it alters the biomechanics. How it alters the biomechanics? It shifts the center of gravity in front, because of which all the load travels through your spine and increases the disc degeneration, muscle deconditioning, and chronic inflammation. How chronic inflammation is a part of this? Because adipocytes, TNF alpha, all these chronic inflammatory markers are exaggerated in this. So healing is reduced. So if nerve irritation is there, it is going to be reduced in these patients. This is how disc pressure is there. If you see, this is 100% when we are standing. When we are bending forward, it is 150. When we are bending with a weight, it is 220, and it is maximum when we are trying to lift something when we are sitting. If we are doing this movement, the maximum disc pressure is going to be in this position. And these all parameters double in a more, it is 50% more in an obese patient. Common spine problems in OPD in these patients are mechanical low back pain, disc prolapse, cervical spondylosis, facet arthrosis, and spinal stenosis. Today we are going to focus more on disc prolapse. I'll just rush through all the other topics so that we can focus on the main topic. So low back pain, most common presentation, chronic and mechanical, and it worsens the prognosis. Disc degeneration, it causes accelerated disc degeneration, disc wear is there, higher prolapse risk is there, sciatica and radicular pain is the presentation which is going to. So degeneration, you can see the prolapse, the disc extrusion, and there is the sequestration. After that, cervical spine issues are increased. It presents as cervical headache, spinal stenosis. It presents as claudication, in which patient walks for a certain distance, and then after 15 minutes, patient has to sit. That is a compulsion for the patient because of the severe pain. This is normal disc. This is moderate stenosis, and this is severe stenosis. So before I start with evaluation of spine, can I know what this person does? Why is this person very famous? Anyone? Detective. So the way Sherlock Holmes detects everything, solves crime by picking up minute details. Similarly, and I'll tell you one very interesting fact, that Sherlock Holmes is based on a surgeon, Dr. Joseph Bell. So जो आर्थर कॉलन डॉयल जो इसका ऑथर है, वो इनके पास इंस्पिरेशन लिया. जैसे डॉक्टर जोसेफ अपने पेशेंट्स को आते हुए देखते, बैठते हुए देखते, उनका एग्जामिनेशन करते, माइन्यूट डिटेल्स को पकड़ के उनके डायग्नोसिस पे आते. उसी बेसिस पे इंस्पिरेशन लेके ये शर्लॉक होम्स सीरीज बनी है जो आज हम जानते हैं और देखते हैं. वैसे ही हमें क्लिनिक में ऐसे पजल के पीसेस को कलेक्ट करना है और एक सिंगल पजल को करना है. अगर एक भी पीस मिसिंग होगा तो पजल सॉल्व नहीं होगी. सिमिलरली जैसे ही पेशेंट आया तो हमने पेशेंट का पहले पूरा सुनना है कि क्या हिस्ट्री है. 90% डायग्नोसिस हिस्ट्री के बेसिस पे बनेगा. देन हमको एग्जामिनेशन करना है. एग्जामिनेशन के बाद एक्सरे के ऊपर जाना है, एमआरआई के ऊपर जाना है, एंड अदर इन्वेस्टिगेशंस के साथ हमको डायग्नोसिस करना है. बट यूजुअली क्या होता है क्लिनिक में, पेशेंट आते ही हाथ में पहले एक्सरे पकड़ाता है, कहता है कि सर एक्सरे देख लो, मुझे L4F5 है. सो विच इज़ वेरी कॉमन. बट हम उसके चक्कर में पहले एक्सरे देखा, फिर पेशेंट की बात सुनी, उसमें हमें लगा कि हाँ L4-5 लिस्थेसिस है, उसके कारण शायद प्रॉब्लम होगा. डायग्नोसिस हमारा पहले ही बन गया बिकॉज हमने पहले सुना नहीं उसका, एंड इसके कारण सारा क्रम्पल हो जाता है. सो अ डॉक्टर हु is not able to take a good history and a patient who is not able to give a good history are both at risk of receiving and giving bad treatment. So I'll just go through quickly with the pain, with the history and examination part. Pain is the most common. We have to see what is the location of the pain: neck, back, upper back, mid back. What are the onset, duration, and progression, aggravating, relieving factors? Then is there any radiculopathy associated? Is there any bowel and bladder symptoms associated with it, such as incontinency, frequency, urgency? Function, we have to see whether there is limitation of activity. Etiology, we have to notice. Based on these, we have to understand whether trauma is the cause, infection is the cause, tumor, and other illnesses such as malignancy. Birth history, we have to note. Past history, we have to see if there is any similar episode in this patient, and is there any relief from preoperative symptoms after previous surgery. Examination, These are the 5 major uh, things that we have to go through: look, feel, move, measure, neurological and other symptoms. We have to see sagittal and coronal balance. We have to feel for local warmth. Anyone wants to add to this part? Okay, so movement, we have to check lumbar spine flexion, extension, rotation for the thoracic spine. Then we have to measure for ankylosing spondylitis patients. You have to see all the tension signs. One tension sign was just now demonstrated, that was a sitting SLR. It is very common and very easy for all of you, where OPD is very fully booked and you don't get time to make every patient lie down. So you can see a sitting SLR and then rule out and identify the patients who need acute intervention. Then entire spine we have to see: sacroiliac joint, hip, knee and other joints. So what happens if what advice are we going to do give to these obese patients? Try to lose 5 to 10% of body weight. Even if the patient loses 5 to 10% of body weight, then also it is a very helpful for the patient, because the disc degeneration exponentially reduces with just 5% reduction. So 100 किलो का आदमी 5 किलो भी घटाएगा, उसको आराम हो जाएगा. It reduces pain, improves mobility. Physiotherapy has a very crucial role. Patient needs to do core strengthening. They need to do mobility exercises, posture correction and aquatic therapy. Chiropractors, not so good in this situation. Now coming to our main topic, slip disc in these obese patients. So what are the red flag signs? Something that gives a warning sign of trouble. Munna is going to help us go and understand it better. So what are red flag signs? When the patient has bilateral radiculopathy or gallbladder incontinence is there, saddle shaped sensory loss is there. Saddle is a seat of a horse. So उस area का numbness होना is a very typical in these patients. And gait difficulty. Patient चलते चलते कई बारी हो सकता है कि वो गिर जाए because of the neurological weakness. ये indicate करता है कॉर्डा इक्वाइना syndrome. अब पेशेंट अगर चलते चलते गिर गया तो हमें लगेगा कि कुछ और कॉज हो सकता है, बट डेफिनेटली हमको सोचना है कि इट कुड बी कॉर्डा इक्वाइना सिंड्रोम. रेड फ्लैग साइंस: लेस देन 20, मोर देन 50, मैलिग्नेंसी हिस्ट्री, गेट एबनॉर्मेलिटी, हिस्ट्री ऑफ ट्रॉमा और स्टेरॉइड इनटेक, इम्यूनोसप्रेसेंट्स सच एज टोफासिटिनेब and history of malignancy. So I'm going to give 7 rules in slip disc which are very important to look and which are very important to decide the treatment of slip disc. Rule 1 is this: there is only one emergency in spine cases, that is cauda equina. Happens in less than 1% patients. Symptoms वही सारे आएंगे: ball bladder, saddle anesthesia, lower limb weakness, paresthesia, and surgery is very required in these patients. You can see the huge disc that is present in this patient. Massive disc compressing. जैसे मुन्ना का एक ही दुश्मन था, स्पाइन वालों का एक ही दुश्मन है. Natural history is to resolve because conservative treatment works in these patients. Thumb rule is conservative for all patients. Acute patients में 95% chance है कि it is going to resolve. एंड क्रॉनिक पेशेंट्स हैं जिन्हें क्रॉनिक पीआईडी है, उसमें 90% गुड रिजल्ट्स हैं. सर्जरी के लिए सिलेक्टेड पेशेंट ग्रुप्स हैं, बाकी सबको जादू की जप्पी देनी है. उसके अलावा कंजर्वेटिव ट्रीटमेंट में कंट्रोल करना है पेन को. वी हैव टू डू लाइफस्टाइल मॉडिफिकेशंस, वी हैव टू स्टार्ट फिजियोथेरेपी एक्सरसाइजेस. दिस वी हैव टू डू फॉर 3 to 6 weeks. आफ्टर 6 weeks we have to assess whether the symptoms are reducing or not. If not, then we have to know why. So अगर कंजर्वेटिव ट्रीटमेंट फेल हो गया तो उसको मामू लेट जा नहीं कहना है, उसको असेस करना है कि क्या प्रॉब्लम था कि इसको ये करेक्ट नहीं हुआ. सर्जरी के लिए नेचुरल हिस्ट्री क्यों नहीं वर्क की है चेक करना बहुत ज़रूरी है. सो कमिंग टू रूल 4, जैसे किसी पेशेंट में रिलीफ नहीं आया तो हमको देखना है कि whether there are any extra spinal causes for that. अगर एक्स्ट्रा स्पाइनल कॉज है, जैसे कि इस पेशेंट में देखते हैं हम, 23-year-old मेल है, लो बैक पेन है since 6 months, right leg pain is there, difficulty in walking, sitting, sleeping, knee pain and thigh pain is there more than calf pain, and SLR is positive at 30 degree. SLR पॉजिटिव है तो हम लोग तो जाहिर सी बात है कि सोचेंगे कि शायद स्लिप डिस्क होगा, बट MRI इसका एकदम नॉर्मल है. सो इसीलिए हमें स्पाइनल मस्कुलेटर्स के बारे में जानना है, जो कि मिमिक करते हैं स्पाइन की कंडीशंस को, बट स्लिप डिस्क नहीं होते. हर स्पाइन का पेन स्लिप डिस्क नहीं होता. सो और क्या हो सकता है? सो फैसेट सिंड्रोम हो सकता है, फैसेट सिस्ट हो सकता है, सेक्रोआइलाइटिस हो सकता है. जैसे इस पेशेंट में देखिए यहाँ, ये सेक्रोआइलियाक, उसी पेशेंट में जब चेक किया एक्सरे, तो राइट साइड का सेक्रोआइलियाक जॉइंट वाज इन्वॉल्व्ड एंड हेजीनेस वाज देयर. MRI में भी same picture correlating was present, and other conditions such as non-compressive myelopathy needs to be seen. Rule 5 is that structure cause to symptoms need to be seen. What that means is कि X-ray MRI should correlate with the patient. सारे symptoms correlate होने चाहिए and बहुत ज़रूरी है. जैसे इस पेशेंट में अगर हम देखते हैं 57-year-old male, right leg pain, L45 PIVD. कुछ किसी को इस MRI में कुछ अलग दिख रहा है या सिम्टम मैचिंग मिसमैच दिखता है क्या? राइट साइड. ओके, सो दिस इज नॉट मैचिंग दैट. वेल पॉइंटेड. एंड वन मोर थिंग आई वांट टू एड्रेस इज दैट पेन इज इन द राइट लेग एंड MRI इज शोइंग डिस्क ऑन द लेफ्ट साइड. सो डेफिनेटली इतना ह्यूज डिस्क है, बट दिस इज नॉट द थिंग दैट इज कॉजिंग हिज सिम्टम्स. सो इसमें फिर और कुछ इवेल्युएट करना ही पड़ेगा हमें. लेट्स सी केस 2. पेशेंट को लेफ्ट एंटीरियर थाई पेन है एंड L5S1 में इतना बड़ा ह्यूज डिस्क है, लेफ्ट साइड है, यहाँ पे भी लेफ्ट साइड है. फिर तो कोई दिक्कत नहीं है. फिर क्या प्रॉब्लम हो रही है इस पेशेंट में? सो L5S1 PIVD कैन नेवर प्रेजेंट विथ एंटीरियर थाई पेन. सो मिसमैच आया वापस. L23 का डिस्क होगा तो डेफिनेटली इसमें सोचता था मैं, बट L5 का डिस्क एंटीरियर थाई पेन नॉट मैचिंग. वी हैव टू लुक फॉर एनी अदर कॉज. रेडियोलॉजी, जैसे कि ये पिंकी और ये पिंकी सेम नहीं है, वैसे ही उस पेशेंट में भी सिम्टम्स एंड MRI सेम नहीं है. वी हैव टू सी डर्मेटोमल पैटर्न, मोटर वीकनेस, वी हैव टू सी टेंशन साइंस, स्पेसिफिक साइंस वी हैव टू सी. L45 L5S1 की पैथोलॉजी को देखना है. एंटीरियर थाई पेन है तो फ्यूमरल नर्व का इन्वॉल्वमेंट हो सकता है, वो देखना है. 6th रूल सेज कि प्रोग्रेसिव वर्सनिंग, जैसे इनके आते ही इसका प्रोग्रेसिव वर्सनिंग चालू हो गया था, तो वैसे ही हमें पेशेंट का नेक्स्ट विजिट में जैसे ही अगर आया तो पिछली बार से सिम्टम्स बढ़ गए हैं, तो वो एक अलार्मिंग साइन है, उसमें सर्जरी की जरूरत पड़ सकती है. एंड जैसे इस पेशेंट में हम देखते हैं 34-year-old मेल है, L45 PIVD है, सब मैचिंग है, बट इसमें सर्जरी नहीं करेंगे क्योंकि इसके सिम्टम्स रिजॉल्व हो रहे हैं, पार्शियल रिलीफ आ गया उसको, एंड इसके और कोई फंक्शंस अफेक्ट नहीं हो रहे हैं, और मोबिलिटी इसकी बहुत अच्छी है. सो इसमें हम सर्जरी नहीं करेंगे. एंड लास्टली, अगर इस लेक्चर से आपको मैं 3 चीज़ें बोलूं कि ये लेके ज़रूर जाना है आपको स्पाइन सर्जरी के पेशेंट्स के रिगार्डिंग, तो वो होगी पहली काउंसलिंग, दूसरी काउंसलिंग, तीसरी काउंसलिंग. वेरी इंपॉर्टेंट इन दीज पेशेंट्स टू डू काउंसलिंग, जैसे मुन्ना ने इसकी की थी. एंड लास्टली, व्हाट डू वी काउंसिल देम अबाउट, कि नमनेस कब ठीक होगा, बैक पेन कब ठीक होगा, मोटर वीकनेस, बॉयल ब्लैडर का अगर इन्वॉल्वमेंट हो गया है, अगर पेशेंट यूरिनेट नहीं कर पा रहा है वॉलेंटरीली, तो वो ठीक होगा या नहीं होगा कॉडा इक्वाइना के बाद. सो चांसेस, उसके परसेंटेज कैसे हैं, वो हमें उनको समझाना ज़रूरी है. पोस्ट ऑपरेटिव कोर्स कैसा होगा, सबसे लास्ट में नमनेस जाती है, ये सारी चीज़ें उन्हें बताना बहुत ज़रूरी है. एंड ये 7 चीज़ों का हम अगर ध्यान रखेंगे तो सक्सेस डेफिनेटली मिलेगी इन केस ऑफ स्लिप डिस्क. अब प्रिवेंटिव केयर पे आते हैं हमारे आज के थीम टॉपिक पे. सो हाउ डू वी प्रिवेंट? सो प्रॉपर अर्गोनॉमिक्स, प्रॉपर पोस्चर. स्टेप 1 मैंने नहीं लिखा है, क्यों? क्योंकि वो बहुत ऑब्वियस है कि स्लिप डिस्क इन ओबीस पेशेंट वेट नीड्स टू बी रिड्यूस्ड. स्टेप 2 आता है, बाकी सारा स्टेप 2, 3, 4 बाद में आएगा. स्टेप 1 इज टू वेट रिडक्शन. स्टेप 2 प्रॉपर अर्गोनॉमिक्स, प्रॉपर पोस्चर like this, some supports like these help. Posture correction belt are contraindicated, not at all helpful, they increase your problems. Wrong posture is very, this is wrong, this is right. We have to see ergonomic posture, some standing desk concept is there. We have to do back and neck stretching, constant sitting increases the load in our back, and that's why we need to stretch them every 30 to 40 minutes. Step 4 is neck and back exercises regularly. As soon as you get up in the morning, you have to do some movements, do some stretching like these, and they help a lot. I am very sure कि अभी भी audience में 40% patients हैं जिन्हें अभी की अभी बैक पेन या नेक पेन डेफिनेटली होगा. सो ये सारे स्ट्रेचेस हमें डेफिनेटली हेल्प करते हैं. लाइक दीज ओपीडी में स्ट्रेचेस करना, हर नेक्स्ट पेशेंट के बीच में स्ट्रेचिंग करना इज वेरी इंपॉर्टेंट. हाई हील्स दे डैमेज द बैक. Carrying loads, we try to carry baby or loads, we have to carry it near our body, so that way reduce हो जाता है load जो हमारे डिस्क पे आता है. एंड ओबेसिटी में ये और ज़्यादा हो जाता है, जैसा मैंने बताया, सेंटर ऑफ ग्रेविटी सामने जाने के कारण. सो व्हेन टू रेफर दीज पेशेंट्स? when the conservative treatment is failed, when neurological deficit is there, when there is any instability, or when you are trying to search for best orthopedic clinic where all orthopedic conditions are treated under one roof, then you have to refer. Where to refer? Alpha Ortho. Coming to newer advances in spine surgery. So जैसे पहले के चोर होते थे कि पहले के चोर कैसे आते थे, घर में घुसते थे झांक के, इसी तरीके से आते थे और पूरी तोड़फोड़ मचा देते थे, जस्ट टू फाइंड कि मनी कहाँ है, पैसा किधर है. पर आज के चोर थोड़े स्मार्ट हो गए. हाँ, अभी वो सारे स्मार्ट हो गए, ये सारा तोड़फोड़ ये सब नहीं करनी पड़ती. वो आते हैं, उनको एग्जैक्ट जगह पता है कहाँ है, वो आके उस जगह से पैसा उठाते हैं, चले जाते हैं, काम भी हो जाता है और किसी को पता भी नहीं चलता. ऐसे ही हमारी नई एडवांस टेक्नोलॉजी है स्पाइन की, जिसमें काम भी हो जाता है और डैमेज भी नहीं होता है. सो आज उसका एक डेमो मैं आपको देने वाला हूँ. कई सारी टेक्निक्स हैं, जैसे कि रोबोटिक्स है, एंडोस्कोपी है, मिनिमली इन्वेजिव टेक्निक्स है, ट्यूब्स है, ग्रेट नेविगेशन टेक्निक्स हैं. इनमें क्या होता है कि इंसिजन इज स्मॉलर, फास्टर रिकवरी, लेस टिश्यू डैमेज, एंड रोबोट असिस्टेड फ्यूजन इज देयर, एंडोस्कोपिक डिस्केक्टमी इज देयर, एमएसटी, एक्स लिफ, ओ लिफ, टी लिफ, बहुत सारे लिफ्ट्स हैं. बट इस सब का एक ग्लिम्स मैं आपको आज देना चाहता हूँ. थैंक यू. पकड़ कर सो आई होप आप सब देख पा रहे हैं. So this is Mr. Spinetastic who's sitting here and he's going to help us understand कि ये टेक्निक्स कैसे इतनी अच्छी हैं, क्या अलग होता है. अभी मैं आप सबको देख पा रहा हूँ, ऐसे ही ओटी में हम सब कुछ देख सकते हैं, पेशेंट सामने है एंड उसके ऊपर ये सारी ट्रेसिंग हो सकती है. अब मैं आपको बताता हूँ कि ओपन सर्जरी में क्या होता है. सो अगर हम देखें कि इतनी सारी मसल्स जो हैं इनको कवर की हुई है, so I have to remove them one by one. Just a second. So I have to remove these muscles. चलो घूम जाओ आप. ठीक है. So पहले फेशिया आता है, thoracolumbar fascia गया, then deep fascia of back गया, राइट एंड लेफ्ट साइड से. लैटिसिमस डोर्साई मसल्स को मैंने स्ट्रिप ऑफ किया, अगर थोरासिक लेवल है तो ट्रेपेजियस को स्ट्रिप ऑफ किया, सेरेटस पोस्टीरियर इंफीरियर को स्ट्रिप ऑफ किया, देन इलियोकोस्टाइलस लंबोरम को थोड़ा रिट्रैक्ट किया, फिर मैंने लॉन्जिसिमस थोरासिस को पकड़ा, थोड़ा सा साइड किया दोनों साइड से, देन मल्टीफिडस मसल जो कि बहुत इंपॉर्टेंट है बैक का एक्सटेंशन मेंटेन करने के लिए, इसको साइड किया. ये देख सकते हैं आप लोग कितनी सारी मसल्स मैंने इधर उधर की हैं अभी. फिर अगर और अपर थोरासिक लेवल है या मिड थोरासिक लेवल है या अपर लंबर है तो स्पाइनलिस थोरासिस को मैंने अलग किया. सेम वे इस साइड पे भी मैंने स्पाइनलिस थोरासिस को अलग किया, तब जाके मेरा स्पाइन आया. सो ये पुरानी टेक्निक्स डेफिनेटली इसको रिप्लेस नहीं किया जा सकता. ओपन सर्जरी अभी भी गोल्ड स्टैंडर्ड है जिससे कंपेयर होती है चीज़ें, बट 90% पेशेंट में मिनिमली इन्वेजिव टेक्निक्स के थ्रू ये सर्जरी की जा सकती है. जैसे ये सारी मसल्स को मुझे वापस रखना बहुत आसान है, इससे रिकवरी अच्छी होगी एंड ये सारा चीज़ प्रिजर्व होगा. कैसे मैं ये चीज़ कर पाऊंगा? सो विद द हेल्प ऑफ अ सियाम और नेविगेशन और एंडोस्कोप, मैं डायरेक्टली ये बोन्स देख सकता हूँ, राइट। सो अगर मैं ये बोन्स देख पा रहा हूँ, सो मैं एक वर्टिब्रा को निकाल लेता हूँ यहाँ पे। लेट्स सी, इसको थोड़ा बड़ा कर देते हैं अच्छे से। आप सब देख पा रहे हैं? दिख रहा है, राइट? ओके। सो जस्ट थोड़ा एनाटमी, दिस इज वर्टिब्रल बॉडी, दिस इज पेडिकल, दिस इज सुपीरियर आर्टिकुलर फैसेट, दिस इज लैमिना, एंड ये हो गया स्पाइनस प्रोसेस। अब जब मुझे जाना सिर्फ इस पेडिकल में है, इस पेडिकल में इस डायरेक्शन में जाना है, इस पेडिकल में इस डायरेक्शन में जाना है टू फिक्स अ स्क्रू, तो ये लैमिना को निकालने की ज़रूरत नहीं, इस फैसेट को डिस्ट्रॉय करने का ज़रूरत नहीं, सारी मसल्स को प्रिजर्व कर सकता हूँ बेस्ड ऑन दीज एक्सरेज। इसको अभी वापस डाल देते हैं हम। अब अगर हमको इसमें सर्जरी करनी है, ओपन सर्जरी, तो हमको इंसिजन लेना पड़ेगा इतना बड़ा, कम से कम L4-5 पे अगर जाना है तो। अगर हमको मिनिमली इन्वेजिव ये अगर हमको ओबीस पेशेंट में करना है तो ये और इतना बड़ा हो जाएगा ताकि रिट्रैक्शन इजी हो जाए और स्क्रूज इजीली जाएं। बट अगर मैं मिनिमली इन्वेजिव टेक्निक्स को अपनाता हूँ तो ये सारे इंसिजन हार्डली ऐसे छोटे छोटे ट्यूब्स के जैसे हो जाएंगे। सो ऐसे 4 ट्यूब्स जो कि स्किन से बाहर आएंगे, एंड इन 4 ट्यूब्स की मदद से हार्डली पेन होल का इंसिजन, की होल इंसिजन से सर्जरी हो जाएगी विद दीज 4 इंसिजन्स। एंड ये स्पेशलाइज्ड ट्यूब होते हैं जो कि आते हैं, ये ट्यूब सारे निकल जाएंगे, सिर्फ स्क्रूज पीछे रह जाएंगे। सो दैट इज हाउ न्यू एडवांसेस इन स्पाइन सर्जरीज आर देयर। इसके अलावा एक और इंटरेस्टिंग चीज जो आपको मैं बताना चाहूंगा लास्टली इज how 3D CT planning can be done preoperatively. So स्पाइन का MRI, यहाँ पे लोडिंग काफ़ी लंबी थी, सो आई हैव चोजन ब्रेन MRI, एंड लेट मी जस्ट गिव यू अ ग्लिम्स ऑफ इट हाउ things are evolving. Can you see? Are you all able to see? Yeah, let me put this in one side. Spine-tastic को थोड़ा साइड में रख देते हैं, and let me put this as well साइड में. Okay. So if you can see, ये ब्रेन का MRI मैं इतना पूरा तरीके से उसको जूम आउट जूम इन कर सकता हूँ. अगर मुझे देखना है कि इसका, मुझे समझो सैजिटल सेक्शन देखना है, सो ये सैजिटल सेक्शन हो गया, मैंने पूरी तरीके से देखा. ये 3D रिकंस्ट्रक्टेड सैजिटल सेक्शन है बेस्ड ऑन द रियल डाइकॉम इमेजेस प्रोवाइडेड. अगर मुझे इसका एक्सियल कट देखना है तो मैं एक्सियल कट देख सकता हूँ. मुझे अगर इसका कोरोनल कट देखना है, सो इसको थोड़ा घुमा देते हैं, एंड मैं कोरोनल कट देख सकता हूँ इजीली. इसी चीज़ को अगर मुझे MRI के बेसिस पे देखना है कि MRI इमेज कैसा दिखेगा इसका, सो ये MRI इमेज उसकी सामने आपके. सो ये हो गया कोरोनल, ये हो गया एक्सियल, एंड ये हो गया सैजिटल. देख पा रहे हैं आप? सो इसीलिए अभी टेक्नोलॉजी के साथ चीज़ें बहुत इवॉल्व हो गई हैं, एंड ये सारी चीज़ों के थ्रू हम बेटर सर्जरीज कर पा रहे हैं. So take home message is that obesity worsens spine health. It treats, we have to treat the weight as well as the pain. GP role is very crucial in these patients, and proper examination is very important, through which we understand what patients we have to operate, what patients these procedures can be done, and newer advances have really rapid recovery. You can take a screenshot or a photo of this, through which you will be able to see all the exercises, the basic exercises, shoulder, back, knee, all the exercises in which जैसा patient normal है, सिर्फ degenerative back pain है, तो ये exercises देके वो ठीक हुआ है. इसमें curated videos हैं जो कि आप शो कर सकते हैं. जस्ट गूगल से स्कैन करके या फोटो ले लेंगे तो भी हो जाएगा. चलो, थैंक यू एवरीवन.
Audible? It was really deep and wonderful to see this presentation. So
Thank you,
now
ma'am.
I call upon the team of in charge of Hall A, Dr. Purvi, Dr. Jaisal, to please assist and guide Dr. Gaurav Ranglani towards the KMA's Wall of Fame and felicitate him.
Okay.
We also thank Orfret Healthcare Pharma, the session sponsor, to be felicitated at the KMA's Wall of the Fame. Can we have the quiz, please, AV team? Friends, the quiz is here. We have 30 seconds to feed in the answer. Till that time, I would like to introduce the next panel speakers. We have Professor Dr. Ketan Mehta with us. Then we have two young dietitians, Nupur Mehta and Jignasa Raja. So Dr. Ketan Mehta, he is the president of the IMA Mumbai West, practicing general physician at Suchak Hospital, Namah Healthcare, Asian Heart Institute and Criticare Asia Hospital. We have Nupur Mehta, who believes in giving a holistic health approach to the patients, consulting dietitian at Suchak Hospital, Criticare, Health Harmony, Spenta Women's Care, Nalini Hospital, Mumbai. She's also the founder at Poshtek, Mumbai.
I think this chair. Yeah. Very good afternoon to one and all. And at the onset, let me thank team Kandivali Medical Association, my dear friends Utpal, Saurabh, Aarti, and entire team. Now, today what we are going to discuss is definitely a different topic, because since today's theme which was planned on obesity, so we will be having a panel discussion of dietary prescriptions in the era of anti-obesity medications. You have heard of so many now drugs which has been bombarded. Do they still matter? And of course we have two young dynamic clinical nutritionists with us, so we would be discussing those aspects. So before I, is this working? No, no, I want a slide changer. No. Ah, yeah. Okay. So it is said by Alvin Toffler that the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. And we have learnt about artificial intelligence and the technology which we have seen. So we know and we need to evolve with the time how the things are changing. When we talk about the overweight and obesity, you know, now overweight is termed as a pre-obesity. You have got a pre-diabetes, you have got a pre-hypertension. So now overweight is termed as a pre-obesity, and it is a medical condition which is marked by an abnormal and or excessive accumulation of body fat that presents a risk to the health. By standard definition, as per the international standards on the BMI, when you have a BMI more than 25, I know this gathering does not need how to calculate BMI. So when it is more than 25, it is overweight, more than 30, it is obese, and more than 35 is severe obesity. Though the cutoff points for Indians have changed, but today, when we are talking of the era of medications, it is still by the international standards. So we will go as per this. And why we are talking over here? A time was there when we were talking about undernutrition, and now the time has come. We are talking about overnutrition, and India is a weighty problem. 1 out of every 4 is obese. So we have a 450 registrations. If you think is at least 100 plus would be either overweight or obese. Would you agree? Yes, that is there. So we all are at risk, we know, and this is the data which is this. And you know, the Time magazine has beautifully covered the recipe for obesity for Indians. You know, take technology which reduces physical exertion, increase calorie consumption, You have video games, televisions, computers, and you stir in an intensive marketing of candy and fast food and the epidemic of obesity which has started. Now, is obesity only a result of imbalance between calorie consumption and calorie utilization? That was the initial concept about it. But there are many paths which can lead to obesity, like biological, genetic, psychological, social, medications, and environmental factors are there. We will not go into the details of it. And today's conference, which is predominantly focusing on obesity, you know, it is a gateway to more than 200 diseases. You name the stream and it will have an impact. You have heard of neurology, orthopedics, be it gynecology, metabolic physicians. So you have a multi-disease which is originating. The mother is nothing but the obesity. So what are the current options in obesity management? We know the lifestyle, the previous speaker has already spoken about it. The efficacy wise, obviously lifestyle has efficacy, but then you go to medications, which is a more, then you have an endoscopic procedure. You have heard Dr. Manoj speaking on that. And then there are surgical procedures which has been talked about. So as we go higher, the risk increases, but efficacy also increases also. So 4 fundamental determinants of lifestyle, which is ahar, vyohar, vichar, and achar. Now what are these? Ahar is nutrition. That nutrition has been given or talked about way back. Of course, vyohar is behavior, vichar is thinking, achar is conduct. And you have newer drugs which are available for treating obesity. I'm sure all of you are aware about it. Liraglutide, which is a GLP-1 receptor agonist, semaglutide, which is also GLP-1, and tirzepatide, which is a dual agonist GLP-1 with GIP. And I'm sure, how many of you have started using these anti-obesity medications? Please raise your hand. So at least good, I can see couple of people who have already started using, and all these are approved medications. So it is already FDA, DCGI approved medications are there. I would just like to brief you about it, since it is not been spoken about, the role of GIP and GLP-1 in regulation. Now when we talk about GLP-1 activity, what does it do? The stimulation of this GLP-1, which causes effect at the central nervous system by reducing food intake, increasing satiety, increasing nauseating feeling. At the level of pancreas, it increases insulin secretion, reduces glucagon. At stomach, it delays gastric emptying. And the GIP, there are additional hedonic effects. So it has a scientifically proven therapy which has been showing to act on not only for obesity but also for diabetes. And this GLP-1 has an impact as a multiple biological process. So it has a protective effect. Your common questions our patients would have, will this have a side effect? No, in fact, it has a beneficial effect. You look at this GLP-1 stimulation will have a cardioprotective, renoprotective, neuroprotective effect on intestine, alpha beta cells of pancreas, and so on and so forth. But there are certain dietary guidance which needs to be followed, and that is what we would be discussing today, that what are the dietary guidance which needs to be followed on that. Okay, so I would come to Nupur. You have various these anti-obesity medications which are delivering unprecedented weight loss. We have seen that almost to the tune of 15 to 20% weight loss which is achievable with the therapy. So does this change the relevance of dietary prescriptions or redefine their role? What do you say?
So yes, when we talk about these newer anti-obesity medications and injectables that have come in, and they have given fantastic results with the weight loss. But there is one thing that needs to take care of, that diet still remains at the critical core of it. Because when we look at the anti-obesity medication, they do not define the quality of weight loss, whether it's the muscle or whether it's the fat that is being lost. You just see the number on the scale. That is where the role of nutrition comes in. Earlier, when we used to give diets for weight loss, it used to be more about creating a calorie deficit. But now that calorie deficit is automatically being achieved pharmacologically. So our role has shifted. Our role has shifted to protecting the physiology, preserving the lean muscle mass, keeping the micronutrients in place, protecting the metabolic function, and that is how the role of diet has redefined, and it still remains at the critical core of the anti-obesity therapy.
Thank you. So that was the basic concept. People think that now you have a drugs which are available which will do a magic bullet. Yes, it will work, but then you need to have obviously coupled with a good dietary prescription, because somebody who was taking, example I'll give you, eating 500 grams in 24 hours, and now with these drugs they will start curtailing to 200 grams per day. But what you are consuming in that 200 grams also matters, because what is important is do you get the adequate micro and macronutrients out of it, which is equally important over here. So I would come to Jignasha. Who is the right candidate for pharmacologic weight loss therapy? So suppose patients come to you, whether you yourself said no, you just continue with the diet, or at certain point of time you feel that pharmacological therapy is necessary.
Yes. GLP-1 is for patient where obesity is disease, not a willpower issue. And diet modification is important. So here some criteria for GLP-1 patient. First is whose BMI is 30 and above, which we call obese. Second is whose BMI is 27 with comorbidity like high lipid, hypertension, PCOS, sleep apnea, and high sugar. So third is who's have tried lifestyle modification but not getting sustainable result, have tried diet and exercise. So these three type of patient are for GLP-1, and some other is not good, who have severe gastrointestinal problem, frequent meal skipping, and low food intake. So GLP-1 is for patient who is obese and with comorbidities.
Okay, okay.
So right candidate is not just who medically qualify only, but who is ready to combine diet with medication. Thank you.
Okay. So here one point which will be a very take-home message is you need to check BMI of all your patients. If your BMI is 23 and above for Indians, they should be starting on a lifestyle modification. If their BMI is 27 and above with a associated obesity related complication, they should be the candidate for pharmacotherapy. And if there are 30 plus without any comorbidity, still they are eligible to go for a pharmacotherapy. So that point should be very, very clear also. Okay, Nupur, are we over focusing on how many kgs have been lost, or under measuring body composition or functional strength and metabolic health? So there are various parameters which we are looking. People just look at how many kgs, okay, how many kgs you have lost. So is this the one parameter, or you would look for the other parameters also?
So I would say that the number that you see on the weighing scale is a very crude marker for something which is much more intense. I would say we should look at the body composition as to what is the muscle percentage of the person before starting the GLP-1 therapy, in between, and later on. What is the visceral fat? What is the subcutaneous fat levels? You should look at anthropometric measurements like waist circumference. Again, that's a very good mortality marker. Otherwise, you should also look for sarcopenic markers, which is very important in these patients, because if not accompanied with strength training and proper diet, the first thing to lose in the body is the muscle. So you could look for simple sarcopenic tests right in your OPD as well, like the chair stand test. Like you can make your patient stand up from the chair without using support, just to see how good their muscles are, or the hand grip strength, or even giving them the smiley ball and using to check the hand strength. So these are functional tests which need to be taken into account, and not just focusing on the weighing scale. So yes, weighing scale is not an accurate marker of the health, and there are other parameters that you need to monitor as
Okay,
well.
so let's check the strength over here. I would request everybody to keep both their hands on the head. And now get up without support. How many of you can do it? Fantastic. See, this is what you must try and continue doing it, and ask your patients to do that, and that would definitely will give you what is the muscle strength, especially when we are talking in the proximal muscles, and especially for a group of people, those who are on this therapy. Okay, I will come to Jignasha. When appetite is pharmacologically suppressed, you know what is happening with these drugs. What are the most common nutritional and metabolic risk you see in the real world practice?
Okay. This risk occur mainly when medication is not supported by structured dietary plan. So risk are protein remains low, muscle loss is real concern because of lack of strength training. Third is micronutrient deficiency, especially vitamin D, vitamin B12, calcium, iron, especially in women. So, but these risks are manageable with dietary guidance. So, some key point is here. First is protein priority. Second is nutritional dense choice. Third is monitoring body composition, not only weight. And fourth is supplementation if required. So, GLP-1 reduce appetite, not nutritional requirements. It's our job to ensure that all nutrient need meet in spite of smaller meal. Thank you.
So the most important point over here is that yes, if the patient asks you, is there any side effect? Yes, there could be a micronutrient deficiencies which has to be balanced by the support of the clinical nutritionist, and if they are not met with, the additional supplementation of those micronutrients needs to be given. That is most important. Okay, Nupur, this now in talking about patients on GLP-1 based therapies, how should protein intake be rethought? How do you do that? Especially in Indian diets, and now we have a lot of vegetarian population where from veg source protein is limited. So already the appetite is smaller, they are vegetarian, so how do you go about it?
So firstly, one statement I'd like to add here, that most of are vegetarians, but the patients that I see in my clinical practice, there are non-vegetarian consuming patients and still they are on protein deficiency. So because they have certain days of the week where they'll eat, and as such our non-vegetarian consumption is not as much as the Western countries. And in general, we know that India is a very carb-loving country, and protein is deficient in people who are not even on GLP-1. So in GLP-1, it becomes the critical or the core nutrient of importance. Now here, in GLP-1 patients, the first question that we ask is not that are you eating enough? The first question comes, are you ensuring that in every eating opportunity that you're getting, are you taking sufficient protein? Now when we talk about protein, again, we need to ensure that the protein intake is something that is suitable to their lifestyle. As you mentioned, the vegetarian people are majority in India. So again, we need to ensure that we are giving them proper vegetarian sources of protein, even using complementary proteins, because vegetarian sources are incomplete proteins. So complementing the protein, giving them the correct doses. Again, where things are not being met through food, we should definitely look at supplementation, because the appetite is much reduced. That is why we can't expect that a normal person being able to meet up the 50 gram, 60 gram, 70 gram protein, the same will be met up without supplementation to a GLP-1 patient. So yes, protein intake with every eating opportunity that they get is important. It's not just, and again, the protein needs to be distributed throughout the day for the body to utilize it better. So that's how protein needs to be rethought.
So the one of the myth is that non-vegetarians do not have protein deficiency is that needs to be noticed, and second is distribution of protein, which is equally important. Okay, Jignasha, I will come to this. The common side effects which happens with GLP-1 is the GI side effects. So how can it be managed through dietary modification, or then you need, or they need to be on drugs for that? How do you go about it?
Yes, some GI side effects are vomiting, nausea, diarrhea, constipation. but it may be mild to moderate. It not be predictable. So this GI side effect can be managed through diet and structured diet and patient education. So some common strategies are eat slowly and chew well, eat small and frequent meal, stay hydrated, drink plenty of water throughout the day, and include some fluid without sugar like coconut water, buttermilk, etc. Then avoid late night meal and avoid large meal and stop eating when you feel full. So it's prevent nausea especially, and stay active, walking, especially after meal. At least 10 to 15-minute walking after meal help in digestion. Next is some specific strategies like in nausea and vomiting, sip on peppermint tea and ginger tea, and stay in sitting position after meal at least 30 minutes, and eat frequent and small meal. So it's help. Next is constipation. In constipation include fluid and fiber rich food like cooked vegetables, fruits, whole grain, and physical activity also help. So diet modification and correct meal timing correct most of symptoms.
Okay. So this is, we need to reassure to the patients, because patient will come back and ask about those GI side effects. You need to tell them there is temporary, it will happen predominantly when the therapy has started. And once the therapy continues, it fades away. And what is important is this changes which needs to be done. Nupur, do these anti-obesity drugs replace lifestyle intervention, or do they expose how fragile a patient's lifestyle foundation already are?
So definitely it's not a replacement. GLP-1 therapies or anti-obesity drugs, they are just accelerators to the weight loss process. Diet and lifestyle modification still remains at the core, ensuring that you're eating a balanced diet with the correct proportions of the macros and the micros, ensuring you have enough hydration throughout the day. Physical activity. Physical activity should include a combination of both cardio as well as strength training. There are patients who will just go for a walk, not giving any importance to strength training, and that is how the sarcopenic, the muscle loss also happens much faster. So yes, physical activity also remains at the core. Along with this, there are two important factors which are the most neglected ones. One is sleep. Sleep cycle, because your maximum healing is going to happen during your sleep. And I remember that, I see that in Mumbai, kind of a busy city, most of our sleep cycles are also disturbed. So that definitely is the case with our patients as well. So counseling them on sleep is also equally important. And the emotional health, the stress management techniques. All of these lie at the core of the lifestyle interventions. And it's the anti-obesity drugs, they are not a replacement. You need to tell your patients that they are just accelerators.
Good. So that is lifestyle forms whether you are on therapy, surgical modality or lifestyle. I will just take 1 minute on that. It has been nicely said that what should you do? पेट को रखो ठंडा, पेट को रखो ठंडा, पाँव को रखो गरम, सिर को पेट को रखो नरम, पाँव को रखो गरम, सिर को रखो ठंडा, फिर दोगे आप बीमारियों को डंडा. And that is where lifestyle, which is all about, which is there. Okay, Jignasha, now talking about if this therapy, if patients lose weight without structured dietary input, what are the risks which we are taking in a long term? Suppose they take only the therapy, don't have a counseling with the diet, what happens in long term?
Okay. Weight loss without dietary structure, patient often improve number on scale, but compromise in body composition, sustainability, and metabolism. So here are some risks: sarcopenia, yani muscle loss. Second is nutritional deficiency, and third is sustainability. So without dietary structure, protein remains low, and sometimes no variety in food. So it's also impact on poor gut health, because no plant variety and fiber reduce. So gut health also poor. Next is rebound weight because of muscle loss. So resting metabolic rate is also lower. So after stopping medicine, it's sometimes weight is regained. So its diet is very important here. It's not optional, but it's mandatory.
Right. So that is a very important point, because most of patients ask that can they discontinue the therapy or what happens? So if they discontinue, if the lifestyle doesn't change, obviously there would be, over a period of time, there could be weight gain which would be there. So Nupur, in patients who achieve significant weight loss on GLP-1s, how should diet evolve during maintenance to prevent weight regain and nutritional decline?
So here diet, I would like to say, is very, very personalized. Personalized to each and every individual patient, personalized to each and every health condition. We cannot be giving a generic diet to patients, and there will be a change in the diet every few days or few months depending on how the patient is evolving. So when we talk about the GLP-1 therapies, when the patient is on the therapy, the primary objective is to lose the weight. So there we are putting them more on a restrictive kind of a diet, which is undergoing the calorie deficit and achieving their goal of weight loss. But once the GLP-1 therapy is discontinued, then the patient is on a maintenance phase. Here we need to take into account that all patients, they are humans. So सबको इच्छा तो होती है खाने की. Everybody wants to eat variety. So they cannot be on a restrictive diet for lifelong. There in the maintenance phase, we teach them how they can eat all the foods, because there's nothing like a good food or a bad food. It's about the portion sizes that matter. So there we teach them about portion sizes, how they can incorporate variety into their food and preserving the strength. As I have already focused earlier, strength training is very, very, very important. So focusing on their strength, focusing on the variety in the food, and focusing on long-term sustainability. That should be kind of a diet that becomes their lifestyle. They should not think of it as they are on some diet regimen. That is where we achieve the maintenance phase.
Yeah. Okay, as rightly said. So this should be how it should be looked into it. Jignasha, how should clinicians monitor these nutrition-related parameters once obesity medication is initiated, and at what intervals? So if they ask, do they need to go for any labs or anything?
Yeah. Here patients are eating less, so monitoring is very important. First is baseline. In baseline, anthropometry and body composition, weight, body composition in BMI and waist circumference. Second is metabolic marker, lipid profile, renal function test, and HbA1c, sugar, fasting sugar, and liver enzymes. In nutritional markers, vitamin B12, vitamin D, calcium, iron, some risk patients, some patient which diet is very low and vegetarian. This patient need more closer watch. So some patient with appetite is low, food intake is low, and hair fall, weakness, fatigue need closer watch. So practical approach is baseline, then follow up 3 to 6 months and annually and on symptoms base.
Okay, so that would be one thing which is there. We need to convince the patient and that what is the need and how they can go about it. So now what will be, to both of you, the key takeaways for the clinicians? First Nupur, then Jignasha.
So key takeaway from my side, that diet remains the cornerstone in GLP-1 therapies. I'd like you to always remember the 3 M's: the muscle, the micronutrients, and the metabolic stability, which should remain at the core, and we should start redefining success beyond the weighing scale.
Jignasha.
Okay. Every patient on GLP should follow 3 non-negotiables. First, protein in every meal. Second is regular meal timing. And third is periodic nutritional assessment.
Okay.
Thank
So
you.
nutrition is definitely a very important role. I would summarize with the drug which is there, semaglutide, as I mentioned, which is suitable for a BMI more than 27 with comorbidity or more than 30 irrespective of mobility. It can produce up to more than 20% weight loss in 1 out of 3 patients, which is the statistics it shows. It's a sustained weight loss over 4 years, which has been documented, and there is a significant health gains are there. So use it today, as rightly said. Even Alok was mentioning that AI, how it is there. If you don't use this therapy in the era when it is available, it can still become a medical legal issue. People can ask you why it is not used. And obesity, which is something, the mother of all diseases, you should be preventing the complications out of it. So I would end with the Chinese proverb, Chan chuk chiga ching chaka chu ching chaka chu. The meaning of it: superior doctors prevent the disease, mediocre doctors treat the disease before evident, and inferior doctors treat the full-blown disease. We Indians are far superior doctors than even our counterparts in the West. Let us be proactive, let us go for it, and should treat and prevent the things which will be helpful. And as rightly said, you have today, in the era of AI, you should not get deprived. Let us have virtual enjoyment of all the best of desert, so you can avoid them at the end. So thank you so much, and we have 1 minute if you have quick questions or anything. No questions? Okay, as the president says, fine. Thank you so much. Thank you both of you.
Thank you
for
so
this
much to Kandivali Medical Association for having us over.
Thank you, Professor Dr. Ketan Mehta, sir, Nupur Mehta, and Jignasa Raja for addressing a topic of growing importance.